Welcome to Whitman Partners Perioperative Power List for 2023. My name is Carissa Brewster. I'm the staff writer at Whitman Partners, and today we're welcoming Dr. Edna Gilliam, Assistant VP of Perioperative Services and SPD at Nemours Children's Health. Welcome, Dr. Gilliam.
Thank you. Thank you, Carissa. Thank you for having me.
You're welcome.
Yeah, I would say this has definitely been a struggle for us. And I'm sure, unlike other organizations, we are, one thing that's unique about us is that we are in an area where there are many healthcare facilities and we're all kind of vying for, the same positions. And so for us in particular, we really had to think outside the box and, what we can do to attract talent to our organization. So we have put on sign-on bonuses. We have offered referral bonuses, and that really didn't bring a lot of candidates. And specifically in perioperative services, what we had to do was really look at our orientation process and really think outside the box on how we can really recruit talent and keep them there. So one of the things that we did is we created a simulated space in perioperative services. So we have a simulated operating room because what we found is that as we were, interviewing some of our new hires and just asking them, what can we do to make this a better experience for you? We identified that many of them left right after orientation. The number one reason was that how they were being treated. And so post COVID, the staff is tired, they're working a lot of hours, and it was creating a little bit of incivility between the staff constantly having to orient the fundamentals over and over again. And so we thought if we could create a simulated space where we could teach them the fundamentals of perioperative nursing. So that way, when they got into the rooms, they would have a little bit more knowledge and be a little bit more independent. So the staff wouldn't have to be training, the fundamentals. So I was able to pitch the idea to my CNO, and we invested some capital funds into, taking one of our old GI rooms and making it into a simulated space. So we have a simulated operating room within the OR proper, and we do a lot of simulations in that space. So one of the things we did was we included our surgeons. So we have them come to the space and, talk to the teams about some of their most complex cases, room setup, instrumentation, how they set it up, how they, and it's a low stress environment. So they get to ask questions, they get to meet the surgeon and build relationships before they go into the room. And that has made all the world difference. We hold monthly luncheons with them just to kind of find out how are things going, what else we can do to continue to improve their experience. So we created lunch buddies because one of the orientees said, this is great, but it would be nice if someone ate lunch with me. Something so small, but made the biggest impact. So we assigned lunch buddies, somebody to help you, get from the OR to the garage, like the little things.
It sounds like orientation. My son started high school in September,
yes.
And that's basically what happened. They held the freshmen's hands, and it's a huge school, so they led them around, told them where to go. It sounds exactly like a freshman orientation.
Right. And you have to really go back to the basics because you think, unfortunately, there's not a pool of experienced nurses out there. So you're really having to train new graduate nurses. And so you think about that feeling, stepping into a new career in this big hospital with all these people you don't know. And so someone eating lunch with you just makes the difference. So
Yeah.
that has been very helpful to us. So we went from, in a 12-room OR, we went from having like a 14, 15 FTE vacancy to being almost fully hired now. So we are very excited about our program. We even went the route of developing partnerships with some of the local colleges and universities. And we've created nurse faculty positions where one of our nurses is actually teaching a Periop 101 course at the college or university. And then we're bringing in those students to fulfill their clinical rotation at our hospital. So we're kind of building that pipeline of constantly having new nurses come into the system. So far, that's been really effective.
Yeah, that's great. You actually answered two questions at once. How do you attract people and how do you retain them?
Mhm.
So that's amazing.
Yes, yes. And it's been amazing. And we definitely see a difference in the orientees. Probably 8 or 9 months ago, we would have, new nurses just crying. And I'm like, oh my goodness, how do we change this? Like, it shouldn't be this painful. And like you said, it was going back to the basics and, you know, like it's the first day of school, right? Same principles.
Yeah.
So, in my position as the assistant VP, I have oversight over our main campus operating room and two ASCs. And we just recently sunsetted one of them because we're getting ready to build another one. But I think the number one thing I found initially was that it was inconsistencies in workflow, uh, practices, processes across the board. Down to the fact that you would have the same surgeon doing procedures in the main campus and in the ASC, but yet they would have completely different surgical trays. And it's like, why is that? An SPD, for example, at the main campus, the SPD techs would have certain competencies and in services that, the SPD techs, out in the ASCs didn't have. And so one of the things that I did, I had our SPD manager take over all three sites. So that way we can ensure that each SBD tech receive the same education, the same competencies, and the same in-servicing. We have her go out to the facilities to make sure that they have the same practices, the same processes. And it was a big undertaking initially. But that has proved to be very successful. Same thing in the OR. Um, e- Even with our operating system that, our EMR, the navigation bar looked very different at each facility. And I'm like, how does that happen? So I think that was very surprising for me, taking
That
over
is
this role.
kind of cool that little detail you noticed. Like,
Hmm.
it's different here, but it looks different there.
Right.
And it can make a difference in somebody's
Oh,
like mental
absolutely.
state when they're like working and like, oh wait, this looks different. And then you lose a couple minutes, and then a couple minutes turns into 30 minutes. You know?
Absolutely. And the funny part about that is post COVID. So these three facilities are in three different states: New Jersey, Delaware, and PA. And so post COVID, we put out an initiative for all of our nurses to be tri-licensed. So that way they would be able to go to any facility, if we had a staffing crisis. And so as the nurses started to rotate, they were the ones who identified, hey, the navigator bar doesn't look the same. What you have here, we don't have that at our facility. So it was good, for them to rotate because they were actually bringing a lot of these inconsistencies forward. I think what has changed about my leadership style is that you really have to think outside the box now. You really need to think outside the box. There is definitely a new normal post COVID, and you have to be willing to take a risk. And that's very hard when the staff is tired, they're unhappy. And, I just talked about, an initiative to have all of our nurses tri-licensed in perioperative services. And that did not go over well. People were upset and angry. Why do I have to do this? And plus there's the difference between working in the ASC and working in a main hospital. I don't want to go to the main hospital. I don't want to have to do all that critical, you know, those critical cases. I like being in the ASC Monday through Friday, no holidays, no weekends, no call. And now you're telling me I have to go to the main campus. So yeah, it was very difficult, but we tried to keep the lines of communication open, give the rationale as to the why. And I think everybody started to understand as each facility hit, staffing crises, that we were able to send help. Whereas before we wouldn't be able to do that. And what we found is that those people that went out to those other facilities actually did enjoy it and wind up taking permanent positions there. So
Yeah, a lot of fuss for maybe nothing.
exactly. But that's
And people don't like
that's
change. People, they don't like change, and they imagine all these things that'll happen from the change, but they don't imagine maybe the good things that'll happen from the change.
absolutely. I think that is probably one of the biggest struggles, but I would tell you that um, the virtual world has made all the difference. That was the one good thing that came out of COVID, is the fact that, we can use platforms like Zoom and Teams, and WebEx to be able to, continue to have visibility. Um, it's often hard to get out to all of the facilities, but I try to team and Zoom as much as I can, to provide opportunity for the staff to see me and ask questions if necessary. I think that the best way to do that is standardization and communication. So we also have a children's hospital in Florida, and we communicate often, whenever we're looking at, end of life equipment, or different contracts. We, work together so that, we have more negotiating power. So, we just recently brought a new robot at our, facility in Delaware. So we, Florida needed a robot too. So we were able to work together, to have more negotiating power. And so, contracts, we try to, be on the same contract. And, so I think it's just communication and, standardization. I'm also a co-lead on our value analysis committee. And so when we have new products that are coming into the organization, we look at those products as a enterprise. And we have a committee, we meet monthly, everybody asks questions. And one of the requirements, of our attendings who are bringing these new products to the forefront, is that they have to connect with their counterpart in either state. So they have to have a conversation that, hey, I'm bringing on this new thing. Is this something that you would be interested in? And so that way we approach it from an enterprise. We do an enterprise-wide trial, and then we make decisions jointly. So that has made the difference. Well, I would definitely say the first and primary is that I'm very happy that we were able to close the gap on our vacancy in perioperative services. So that's a given. But the other thing is, I think back in September, October, we really experienced an increase in RSV and flu, as well as COVID. And so it was creating a little bit of bed capacity issues, because there were so many patients that were coming in to be seen. In the ED, there was a time where we were holding like 30 or 40 patients. And so it was a trying time for us, because we were trying to keep elective surgery moving, but we knew that we had to look at the admissions. because the elective admissions were the only admissions that we could control. And so perioperative services essentially became a self-contained unit. So we looked at all of our surgical admissions. We went back to our physicians and said, hey, does this patient need to be admitted? And what we found is that a lot of it was based on, patient preference, pain management, things like that. So we had to look at it from a different perspective and how we can move these patients to discharge. And so we were able to reduce surgical admissions, scheduled surgical admissions between September and December by 68%. And so because we were able to do that, we were able to keep our elective schedule moving. And so I'm very proud of that.
That's great. That's great. A lot of facilities weren't very lucky. It's like a rehash of 2020 all over
Oh, I
again.
know. I know. And then I have at the main campus, I have a north and south in PACU, and we actually turned one of our PACUs into an inpatient unit. So we were holding 5 to 6 patients in our PACU, and plus they were also recovering patients. So, we really had to bring the team together and think outside the box of how we can continue to move patients along. So we kept many of our surgical admissions in the PACU, and also those 24-hour observation patients, we were able to keep them in our PACU. So we just really became like our own surgical machine in perioperative services as to not impact the inpatient units as much.
Yeah, it's fantastic. Thank you for joining us.
Thank you. Thank you.
Yeah.
This was awesome.